Good morning, everyone. Just be mindful, people might still be joining. But my name is Michelle Donnelly. I'm the Communications and Awareness Lead at the South African Federation for Mental Health. Yeah, it's morning and I guess good evening to our counterparts from Australia joining. Really looking forward to host this wonderful discussion with my co-host Tracy Tavumba, who will introduce herself shortly. So I'm from the South African Federation for Mental Health. We are a human rights-based national advocacy NGO. We focus on advocating for the human rights of mental health care users in the country, but we also focus a lot on raising awareness about mental health for the general population as well. We work with national government at a strategic level, as well as global partners, to ensure that, wherever socioeconomic policies are being made, mental health is always included. And we also work with 17 community-based mental health organizations that we call our mental health societies. And they provide the much needed mental health care services in communities across the country. You'll find at least one in every province in South Africa. And they work in communities that are quite often vulnerable and under-resourced as well. Thank you again for joining, and I'll hand it over to Tracy.
Good evening, everyone in Australia, and good morning to everyone in South Africa. Thank you so much for joining us. Like Michelle said, my name is Tracy Tavuma. I'm a Zimbabwean Australian person and founder of Tavuma Mental Health. Tavuma Mental Health is a clinician-led, virtual, inclusive, and culturally responsive mental health service. We specialize in accessible trauma-informed therapy and wellbeing support for Black, African, and underrepresented communities across Australia. It is such an honor to welcome everyone here to this joint webinar with the SA Federation for Mental Health on the topic of culturally safe and responsive mental health care. Before we begin, I would like to take a moment to acknowledge the Darol people, who are the traditional custodians on the land on which I live and work. I pay my deepest respects to elders past, present, and emerging, and to any Aboriginal and Torres Strait Islander peoples here today. Let us remember that sovereignty has never been ceded. It always was and always will be Aboriginal land. So for those of us who are joining maybe from across Australia or abroad who don't know what an acknowledgement to country is, it's a way of showing respect to Aboriginal and Torres Strait Islander peoples who have cared for this land for over 60,000 years and continue to hold such a deep spiritual and cultural connection to it. So feel free to also pop in the chat where you are joining us from today. So it's good to know where everyone's joining. I would also like to acknowledge diversity of identities and individuals and people with a lived or living experience of mental health issues and those who love and care for them. So before we then take a deep dive into tonight's discussion, I really just wanted to start with a few important housekeeping notes. So the session is being recorded, so the recording will be shared on social media platforms after the event. So feel free to turn off your camera if you don't want to be recorded. We'll also be discussing some really sensitive and potentially distressing topics related to mental health and lived experience. So please take care of yourself as you listen, but if at any point you feel like you are uncomfortable, you're welcome to take a break. We also have two therapists from Tavuma Mental Health, Stephanie and Secunda. They're on standby to provide counseling support should you need to briefly speak to someone during the event and 1 hour after the webinar. Then we have also provided this list of crisis lines that are both available in the two countries. We're returning to the final pieces of housekeeping. Please keep your microphones muted during the presentation. Lastly, you can also pose questions at any time in the chat. We will address these questions once all the speakers have finished. So once again, welcome, and we're so glad that you're here. So it is now my absolute pleasure to introduce our first speaker today. Nomankosi Kumalo is a Zimbabwean Australian youth advocate and community leader who is passionate about youth empowerment, mental health, and representation. Norma is a member of Headspace's National Youth Group and Y Canberra Youth Reference Group. Please join me in welcoming Norma as she shares her story and practical recommendations for culturally safe mental health care.
Good evening and good morning to those of us in South Africa. Sabonani Ibuzalami Nomakhosi Khumalo, and As mentioned, I am here in Canberra. I am dialing in today from the Ngunnawal country. So those are the traditional owners of the Canberra region, which I now call home. So my cultural background is Zulu and Ndebele, but I was raised here in Australia throughout my schooling and university education. Today I'll be speaking to you guys on my personal journey living with mental health and the ways in which that I have used resilience and community to help guide my mental health journey. All right, next slide, please. Just a bit of a disclaimer and some trigger warnings. For the next 7 to 8 minutes, I will be sharing my lived experience with mental health. To begin, I wish to provide a disclaimer and trigger warnings. I am not a professional or practitioner or doctor. These insights shared today are based on my own lived experience and my personal journey with mental health. Please do advise that this presentation will include references to self-harm, mental health challenges, including anxiety, depression, and eating disorders. Again, if at any point you feel confronted or uncomfortable, please do take your own time to step out or reach out to a trusted person. Next slide. Here I just have a quote. Mental health problems don't define who you are. They are something you experience. You walk in the rain, and you feel the rain, but you are not the rain. So this quote is a reminder that we may at times in life experience storms. It may seem troublesome, it may seem hard at the time, but eventually we make it through. My story is a reminder that mental health support is not just about the individual, but it is about seeking help and healing through others and community. My key takeaways are expanding scholarships and training pathways for African and multicultural people studying health professions, improve health services so that they are more closer to people of marginalized communities, embed cultural safe practices at all levels, making sure that we are including colleagues and service providers who understand the complexities of those of us from multicultural backgrounds. And finally, the biggest one I would say is coming together as a community to remove stigmas and the shame that often scares a lot of young people and just Africans in general to seek that first initial help. All right, that is me. Thank you guys for listening.
Thank you so much, Norma. That was such a vulnerable way to share your story. So it's such an honor and privilege to be able to hold this space to discuss these narratives. And these narratives do have the power to actually affect change. So thank you so much. I know there are burning questions. So if you can, please make sure you leave them in the chat or hold until the Q&A. So now it is my pleasure to also introduce the next speaker, Dr. Xavier Mulenga. He is a Zimbabwean Australian psychiatrist with subspecialty training in addiction and eating disorder and works primarily in Sydney. Xavier is a mental health advocate in the African Australian community. So please join me in welcoming Xavier as he shares insights on bridging culture in clinical mental health care in Australia.
All right. No, thanks for having me, Tracy. I think you said Zimbabwean Australian, but it's actually Zambian Australian. Um, I should say, I'm a addiction and eating disorders psychiatrist based in Sydney, and I will be talking about the current state of cultural safety in Australia. And yeah, just a few ideas that I think have been helping the community, and some ideas we can look from a systemic approach, sort of, I guess, systems, community, to try and hopefully get a lot of people who have mental health concerns in the African diaspora communities, whether here in South Africa, and sort of just put the ideas together. Next slide. All right, about me and what do I know? So I should say I'm a psychiatrist, so a medical doctor who trained in psychiatry. Like I said before, do addictions, eating disorders, and general psychiatry, which is just another way of saying depression, anxiety, which is another way of saying just depression, anxiety, and also bipolar. So everything else in between. A lot of complex trauma comes into that work as well. I've been working in mental health services in Australia since 2013. Gets older and older as I get on with time. And I've worked in both public and private hospital systems. So at the moment, I actually work in both. So I work in a private hospital where we do admissions for addictions and eating disorders, and also work in community public service government funded institutions as well. I've had experience in both city, so Sydney, Gold Coast, as well as like regional places. So out Western Australia, a lot of other places in between. And the idea is also to engage with lots of people in the African diaspora in workshops. So trying to meet people on the ground and trying to bring that disconnect between services I work for and the community and how we can sort of get them to come together. Next slide. Yeah, so I'm covering three things in terms of, I calling them initiatives, but I always look at this sort of work in three, I guess, spaces in private practice, in the public hospital and community services. That's mostly government-led, government-funded, and also African mental health advocacy, which is more about what we're doing in the community to try and sort of help or bring down these obstacles or barriers. Next slide, please. So in private practice, I often, I've worked in many private clinics, private hospitals, and I often say, it is a business first, so you have to use that to your advantage. So much so that we're actually getting a lot of CEOs and, private practice owners asking, okay, we're getting all these African Australians or just different minorities coming to practice. How can we encourage them to come more? Because they also know there's a disconnect, but they're not the right people. So they come to us, I'm Zambian, so I've got Zimbabwean colleagues, Nigerians, we've got other people from Egypt. So they come ask us, how can we get your client base? And it's also coming from, I guess, altruistic, we want to help you, but also I know it's a business perspective, but it means that we can help model I guess, the practice and the private industry in a sense, depending, to get more people involved. And you're noticing that now because there's not many, I guess, in the public setting, so this is a public hospitals or community centers, lots of long waiting times, not as many clinicians. So a lot of we're noticing African Australians actually going into the private sector. So they're using their money, try and see they get their own private psychologist, private psychiatrist. And as the years go by, we're seeing more and more of this. So we're trying to build the bridges. And in the private practice domain, what they do try and do is diversify the staff. Because often, if people can see themselves in the psychiatrist or doctor or nurse or psychologist, then they can feel maybe this person who's an immigrant themselves, a minority, or could understand my story and might judge me less, or there might be less judgment or stigma in my care. And that's something which is very important. So that's one of the big things that we do. And also promoting the community because we're in private practice. We do have a few more funds and money. So we go to GP practices or general practitioners or primary physicians, where we're from, who actually then talk to them and say, refer patients if you think they need mental health assessments. And that sort of provides a lot of input out there. I often joke that African psychiatrists and psychologists are shy because we're such a small minority. And because our communities, it's 1 or 2, 3 degrees of separation. I think we're often trying to be just in our little bubbles and we're not seen out and about. And we're trying to change this as the years go by. Next slide. Oh, yeah. So in public hospitals and community services, it's interesting because obviously this is the main hub that most people present to in crisis, or if they're having their first mental health episode, or even if they've had chronic mental health care. One, obviously, it's usually free, depending obviously if you're a citizen or permanent resident, or so it's paid for by the government. So access, that financial barrier dropped. So a lot more people were actually seen in the public sector. And to be honest, that's where I've seen most of my African clients in Australia. It is under-resourced to some extent and you know, high level of referrals, which just means that too few doctors, nurses, lots of patients. And as we get along, especially since the pandemic, a lot more people are more mental health aware. They know that there is a need to go see a mental health service, whether it's a psychologist, mental health nurse, or actually a psychiatrist. But then when you go there, you find you're on this long wait list of like maybe 3 months. So that's not ideal. But the good thing about the public, though, the public system is that's where you find the most diversity in terms of doctors, nurses, and care. So a lot of clients have told me when they've gone to private practice, It's usually there's this one black doctor in a very white practice, or but when you go to the public, it's like, oh, I've got Indian doctors, nurses, we've got, people from China, it's African doctors, so they feel there's more welcoming space despite the different disadvantages. Often in the public service, they can only do short-term follow-up just because there's so many patients, and that's sort of something where the shortcut with private practice comes in because we can follow people a bit longer, but at the same time, there's finances involved in that. So it's not 100% a good model, but they can provide short-term care in the public, and they're trying more and more to actually teach more what you call intercultural mental health amongst clinicians, where we're sort of talking, how do you approach people who are stigmatized, don't know anything about mental health? Do we know people who do we use translators in our service? So that's something we heavily rely on to make sure we get the messaging across to people in the community. Um, and often I was going to say the public service caters to all Australians, but obviously when you're doing it to everyone, minorities get missed out in terms of the nuance and the discussion and cultural issues that might come through. So that's obviously a negative that can be worked on, but only so much can be done. The next slide, please. And this is something which I've got more of a passion project. So how do we build those bridges between, and how does this help? So I've sort of labeled this slide the African mental health advocacy page. But once again, I've put African mental health clinicians are shy. So much so, let me just speak maybe for psychiatrists. I don't want to speak for mental nurses or psychologists. Is that a lot of people in Australia didn't know that so many African psychiatrists who are not that visible. It's changing next year. So what we're trying to do is, how do we go into the community? Do we get involved with workshops? Which one of the psychiatrists got time in different parts of Australia to go to local events so that the community know we exist and know how to get referrals to us, how we work, what our different specialities are. So let's say in Melbourne, I already know that two psychiatrists who are really good in perinatal mental health, both Nigerian, very well trained, and at least the community already knows, like, okay, if you've got mental health, pregnancy, a woman, they've got people they can go to, but it isn't as well done in other cities across Australia. So really trying to work on that. A lot of advocacy has to be done from within the community. And so I sort of wrote there, you have to do it ourselves whilst everyone else plays catch up. What I mean by that is before we get either the private practice or the governments reaching this level where they're more actively targeting the vulnerable communities like ours, our community, we have to get forth and do things like these sort of workshops, doing lots of, people do podcasts, people do TikToks, whatever it would be to get the messaging out there that can easily be spread and shared. And hopefully resources that are standardized and actually well informed, because a lot of misinformation out there. And with all the stigma and cultural, a lot of people, even today, someone was asking me that, oh, I'm quite depressed. They said, antidepressants, I hear they're addictive. If I start taking it, I won't get off. And it's also just trying to encourage people with those very nuanced discussions while hopefully guiding them towards getting good mental health treatment. Something I was going to showcase here is that the African Australian Psychiatrists Association is something we only formed this year, which is interesting considering how many years we've had African psychiatrists in Australia. And I think it's just maybe we've got critical mass now. And because we've noticed that there's the Indian Psychiatrists Association, they do the thing, Chinese, Sri Lankan, and we also felt that even though Africa is a continent, so it's a bit tricky because even though we're saying African, it's meaning with Nigerian, Zimbabwean, and there's a lot of different Egyptian, so there's a lot of different countries you're talking about, but it's easier to label it that than try and give it another interesting name. Um, the barrier I often mention, which is like I don't know if it's an unpopular opinion I have, is that when you galvanize all of us together, as I say, black or minorities or African diaspora, sometimes we forget the nuance that there's still some levels of different cultural barriers, xenophobia amongst groups, and you actually see that play out in many different organizations. 'Cause I've been lucky to be involved in things involving Sudanese, Australians or Zimbabweans, Nigerian, and by and large, most of them are good. But every once in a while, you come across and you realize, oh, we're not really as unified as we could be, and just working on that because that becomes the barrier when you think, okay, this country does it this way, we do it this way, we only look after our people, because then that just becomes a problem. The next bit is actually, next slide, sorry. Yes. So the take-home advice I have is for most of these institutions is hiring a diverse range of clinicians, promoting them within the relevant industries, and then collaborating with organizations or practices or individuals in, I guess, African mental health, so even things like Tavuma mental health. And the last note I was going to write is the building is the barrier. This is something a good friend of mine, Andrew, told me. He said that, if your building is the barrier for people coming to get you help, you might have to get a new building. And it was put in the context of if you're outside of a neighborhood that's not familiar to many of your community and you want them to go there and they're scared to enter your building because they don't think it's for them, then that already becomes a bigger barrier than just because you're there, you're willing to help, they won't get to you. And that's it from me. Sorry, I might have gone over time a bit there, but that's sort of my bit.
I'm on mute, sorry. Thank you so much, Xavier. Thank you for that really insightful presentation. And just for sharing that context on the current state of cultural safety in Australia with regard to mental health systems, but also that practical advice for organizations and decision makers as well. Thank you, thank you. Now moving on, I'm really honored to introduce our third speaker for today, Kurt Pretorius. He is here joined with his job coach, Samantha Hendricks. Kurt is a board member of the SA Federation for Mental Health, and Kurt also has lived experience. Kurt has sent us a pre-recorded video, and thank you to Samantha for helping him put that together. And in the video, Kurt really shares his story and his journey since being placed at Training Workshops Unlimited. So Training Workshops Unlimited is one of the programs offered by one of our community-based partners, Cape Mental Health. It's a life and work skills training and development project focused on persons with intellectual disability. And it really does focus on helping them achieve their potential for work, as well as employment in Cape Town and surrounding areas. The programs are really developed at a level suitable for persons with intellectual disability. And the program is also culturally appropriate for the South African context. And it really is focused on helping persons with intellectual disability achieve their potential for work and employment. So thank you, Kurt, for joining. We'll play the video. And if you have anything else to add, you can definitely speak afterwards. Thank you. You can play the video, Tracy.
Hi everyone, my name is Kurt Pretorius. I live with intellectual disability and I live in Cape Town, South Africa.
Hi Kurt, can you tell us what was your experience like when you were looking for a workshop or mental health services? Was it easy to find? Was it easy to navigate? Was it uncomfortable? Was it difficult? Can you tell us more about that?
It was very difficult for me. People who I knew never wanted to help me because they thought I was a little bit down. And then I went to my sister. My sister helped me to look for other workshops. We went to Joburg for a psychologist. A psychologist helped us to look for other workshops, and they wanted to place me in one of the workshops in Joburg. And I said, I don't stay in Joburg, no. I don't stay in Joburg, I stay in Cape Town. And that's how they referred me to look for a workshop in Cape Town. It was very hard for me to get a workshop. Then we came out to see Cape Mental Health, and they gave me a good service, and I liked it, and it helped me very much.
Kurt, were you worried when you were going through the process of finding mental health services for an adult with intellectual disability?
Yes, when I was in a school with skills. After school, I didn't know what to do because everybody was getting jobs and going to colleges. And then I found Cape Mental Health. They helped me very much to be in a workshop, and it gets me very happy. And I'm learning a skill in Cape Mental Health.
How did you find the mental health professionals' communication with you, Kurt, during your process of applying for a workshop or services within Cape Mental Health or any other mental health services? Was the professionals very clear, and did they understand your situation?
Yes, they did understand my situation. It was very clear, and I understand everything now at this time. Because it helps me now to learn about more stuff in my workplace in Cape Mental Health.
Did they attend to your needs, Kurt?
Yes, they did attend to my needs, because if I had a problem, I always go to them, and then they will help me solve that problem.
Kurt, Was there any challenges that you may have faced in your life accessing assistance in any area in your life?
Yes, it was very hard for me to face my disabilities in the hospitals. This was very hard if I was by myself. If I had my sister with me, it was a little bit easier because she understands me. And then I end up finding a place where they understand me for my needs and it helps.
How did the mental health service impact your life, Kurt?
It impacted my life very, very much because I was very disruptive in my workplace. I always had anger issues to myself. I didn't know what it was, then I ended up talking to my supervisors and they gave me more information to calm myself down. And I have more positive things now to think of. I am a board member on KBTR and the Federation Board of South Africa and a training council.
What would you suggest to others, Kurt, seeking mental health support?
I will refer them to my workshop where I work at Mental Health. We'll give them more information and more help because there's more of psychologists in the workshop.
How does it make you feel, Kurt, having a mental health supporter like a job coach, an instructor, or any other professional staff around you? How does that make you feel?
It makes me feel happy to have a job coach because if there's anything I need, I can just go and ask and she will help me. And then it makes it easier for me to understand a lot of things in my workspace.
Perfect. Thank you again for sharing that video, Kurt. I'm not sure if you wanted to add anything else, Kurt, Samantha. Can just unmute.
No, thank you.
No problem. Thank you so much. And just to say, yes, Kurt and Samantha are here. So if you have any questions for them, please do pop it into the chat. And lastly, our final speaker for today, everyone, is Edward Mothana. Edward is a registered social worker and he is also the assistant director at Mpumalanga Mental Health Society, where he manages the Bande office. Edward participates in actions that seek to advance mental wellness, such as policy consultations and research studies. So everyone, please join me in welcoming Edward as he shares more about South Africa's community-driven approaches to enhancing culturally safe mental health care. Thanks, Edward.
All right. Thank you so much, Michelle. Thank you, everyone. Good morning, good afternoon, good evening. I hope everyone is well. I would just love to give an exposition of what Mpumalanga Mental Health Society do in mental health services. So next slide, please. So just to give a brief background of who we are, our organization was established about 3 decades ago, and it has been implemented as a solution or as a measure that we wanted to implement policies or ensure that policies around mental health are implemented and that persons with mental health conditions are protected. Our intervention focus at the grassroots level where we love to reach people at their level. We are found in Mpumalanga. It's one of the 9 provinces in South Africa, and we're operating in the 3 districts of the demarcated districts of the province, but we are also found in 3 these sub-districts of the same province. So our intervention, we have adopted a vision that we would love to see our society becoming dynamic and that we lead in the field of mental health society, of which I believe that we are doing a good job as we are able to embark on a mission to help people achieve their optimal mental well-being by providing support through counseling, do awareness campaigns, linking services, as well as lobbying for the rights of persons with mental health conditions. So our organization, in an annual, we are able to reach over 24 people in preventative measures, where we are able to reach at least 6,000 individuals in case interventions, which also involve their families. Next slide, please. So how we employ a community-based approach is that we have adopted a social development model which seeks to put people at the center. So in order for us to be able to help individuals, we want them to partake in their mental health journey, and unlike doing things for them or just, doing things for them, but also allowing them to participate in the helping journey. So we do this by partnering with other stakeholders in the community, where we engage in preventative and early intervention, where we are able to also engage other community members and increase community participation through engagement with community leaders and other organizations operating in the same organizations or in the same vicinity where we are rendering our services. We have adopted a linguistical preference, where we see that in South Africa we have over 12 official languages, but the social service professionals that we employ, we ensure that they are placed or they speak a language of that particular area. So in general, most of our social service professionals speak over 3 languages, for an example, like English, Zulu, Sepedi, or Ndebele. So they're able to engage our mental health care users in a language that they'll be able to understand. So we'll normally say in their mother tongue language. This will enable them to express themselves freely and eliminate any community or communication barriers that may be involved through the helping process. And we have adopted a community-based approach which allow us to be able to reach people where they are. So this approach also ensures that people have got easy access to us, that we are found in the community where they are. There are no issues of transportation. People can actually walk to our offices to receive mental health care services. We eliminate any other gate entry challenges that they may experience. And also the nice thing is that we're able to engage them even in their homes, do home visits, checking their home circumstances and how it is affecting their mental well-being. And we have adopted a cultural sensitivity approach, where we ensure that we take into cognizance the culture and the belief of individuals that we are rendering our services, especially looking at South Africa being such a diverse country where there's so many people with so many cultural beliefs. So in order for you to be able to render services that effective and efficient, you need to, understand the community where you are. That will also be able to help you to use appropriate tones, be able to acknowledge, what is it that they believe in, and then how is it going to affect their how our intervention is going to be affected by their own beliefs, and also being able to establish that relationship of mutual respect and trust. So psychosocial support, it is at the heart of our intervention. We ensure that we render services that seeks to promote the resilience of our communities, and we are able to do this by practicing what we call Ubuntu. Ubuntu simply means that, a person is a person through other people, and which we're able to implement utilizing our Batubili principle that highlights issues like courtesy, rendering services with courtesy, rendering services, with value for money, for an example, looking at transparency and other things like that. And we also ensure that we are able to look into how historical influences has affected the people that we are servicing. We understand that there's a lot of people who have illiteracy, who are maybe experiencing some mental health conditions and they are not diagnosed. And this is simply because we lack professionals that are able to render or to do tests around mental health or give a clear diagnosis around mental health conditions within our communities. And we also have to understand that there is a lot of resistance and hostility around families in order to help people, for people to go and to look for help. It is quite a difficult situation for them. So issues of acceptance also come into play whenever we engage or whenever we want to help a person with a mental health condition. So all these practical modalities, when we put them into practice, we ensure that our services are tailored in a manner that can be able to help our individuals. Next slide, please. Right, so in rendering our mental health condition in a village or in a rural peri-urban areas of South Africa, we find that there is, I can say, a clinical divide between, the clinical and a traditional divide, that a lot of people would love to get assistance, but clinicians are not able to render all the services because individuals tend to believe in other things. Like, for an example, that I was telling Tracy earlier, that when people seek mental health services, most of the time the first point of contact will be traditional healers, but this is done in secret, because of the stigma that is around the issue of traditional healers in South Africa or in their communities. People will go to see traditional healers, and when they see that things have not worked out, that's only when they will come and seek the intervention of clinicians or mental health practitioners. So there's a lot of stigma around people who utilizes traditional healers, and there's also a lot of stigma around accessing mental health services as well, especially when someone will say, I'm going to the Office of Mental Health, and people come with to an assumption that there is something wrong with you, whereas accessing mental health services is not only about persons experiencing mental health conditions only, but we all need mental health services. So in our approach, in order to be able to bridge the gap between traditional healers and mental health practitioners, we ensure that we practice, self-determination and allow people, to have the freedom of choice, and also be non-judgmental in our approach or in our way of assisting the people that comes into our offices. Next slide, please. Right, so our call as Mpumalanga Mental Health Society is that we will have to, invite all the professionals, the traditional healers, the NGOs, in order for us to expand access to community mental health services. So this way we'll also be able to bring an understanding, because there's so many misconceptions that when we are able to render some workshops or education on mental health, and they also provide some form of education on how we can, integrate the services into our own services, we are able to actively partner with other stakeholders as well as mental health care users in decision making, and also ensure that there is transparency, that there is transformation, and that there is growth. Because right now, looking at how we experiencing, a lot of mental health cases, it shows that there's a really great need of mental health service users, or rather mental health service practitioners. What we have engaged, especially, for example, this month as Mpumalanga Mental Health Society, we did what we call a mental health walk, where we partnered with our stakeholders, and we encourage them that we want them to partake in any action that will build mental health of people. Doesn't matter what they're doing. If, for example, the school have a form or of an option within the school that you are able to render mental health services. If it is a church, let them prioritize mental health services. If it is a municipality, whatever section that they have within that organization, let them find ways that they can render mental health societies. Thank you.
Unmute again. Thank you so much, Edward. That was perfect. Thank you just for sharing more about the amazing work you're doing, but also sharing that great insight into what practical community-based mental health services looks like and what it can look like as well. Thank you again to all of our speakers. We come to the end of the speaker portion, and we're now transitioning into the Q&A. If you do have a question or comment for any of our panelists, please raise your hand, or you can pop a question into the chat. I have been monitoring the chat. I don't see any questions there yet, but please, this is a safe space. If you do have any questions, feel free to raise your hand. I see a lot of comments saying thank you. I see a comment saying joining from Sydney, Australia. Very informative presentations. More of these presentations will break the stigma in our African societies. Thank you, everyone, and the organizers. Thank you so much, Rue. Were there any other questions from anyone? Just seeing if there are any raised hands. Was there perhaps anything else one of the speakers wanted to add? Did any of the speakers have a question for each other? No, we all good. I think everyone's presentation was very clear and insightful, so appreciate it. Were you going to speak? Sorry, Xavier? No, you're good.
Yeah.
Thank you, everyone. I'll hand it over to Tracy.
Great. I actually had a question for Kurt, if that's not to put you on show right now, Kurt, but I just wanted to ask from your board perspective, because you do have such governance oversight on some of these services, I suppose what advice would you give to other organizations trying to do the same thing, which is to improve mental health care and make it accessible to all people accessing it?
You can understand English.
I know I asked the questions in a convoluted way, but I'll just simplify it and say, is there any advice you would give to organizations who are trying to be more culturally safe in their mental health service delivery?
Did you understand that?
Yes, yeah, you must try implement a workspace for the people who have mental health issues. Then you can have a progress with them and see how far they go. You can have a workshop open for them in the mental health sector. And I feel very good to speak out on the board because I learned a lot of things about mental health from where I'm coming from. And also with the Federation Board, I learned more of other mental health organizations because it helps me now to know there is more people going forward with mental health. And allow them to speak for other people in my workspace and outside.
Thank you, Kurt. Appreciate that response. And just had another question for Noma as well. In terms of your representation on the youth reference group, what sort of actions do you think need to be taken from those organizations to make mental health care more culturally safe?
As much as it's a great organization and it is on a national level, These sorts of institutions generally are white institutions, so there isn't that access to Black, Brown, Indian, and all in between caregivers. So having maybe some sort of website or some level where someone of a different culture group can actually go onto the website and select, I prefer maybe an African woman to see me. Or if it's someone who's maybe of Chinese descent, I prefer a Chinese male to see me. So yeah, having just that representation is really important because there are a lot of people. If you think about the Sudanese community in Melbourne, there's been a number of things, particularly with the young men, and there just isn't that support. There isn't that representation, so they don't feel that safety. They don't feel their culture will be understood.
Thanks, Norma. So it's really important that representation is quite emphasized in these organizations and spaces. Thank you for that. Michelle, I think you had another question.
You did, but just quickly, I see there's I think it's a question or comment in the chat. It's just saying, I sometimes get the impression that the client expected and wanted to speak to someone from another race, though they are my race. Any experiences in that? You mentioned that seeing someone from your own and that it would help the process. Sorry, Teresa, I'm not sure if it was a question aimed at someone. Please feel free to unmute and maybe expand. We can also direct it.
I can talk to it if.
Yeah, maybe you can. Thanks, Xavier. Thanks, Teresa, for the question.
Yeah, no, it's very common actually, like where you meet, and I think that's something I also make very clear that there's someone, it depends where they're coming from. So let's take the context. Let's say if I'm from Zambia, back at home, your parents could ring your doctor and find out what was going on with you if you're worried, and the doctor would tell your parents. So doctor confidentiality has a very different meanings if your family and community are involved. If anything, people feel that it's not going to be there. So when they come see me, let's say even another Zambian or Nigerian, or just even black, or even just even different cultural background, even I've had the same thing with Indian, and it's just like it makes pick my race actually. Let's say black on black, you find that they'll say, you know what, can I trust you? And even they say, oh, doctor confidentiality. It's like, yeah, but do you respect that? Because they come from the places where they don't feel safe. And in those cases, then, ask them who they feel comfortable with. So in a lot of my practices, because I'm the only black person in both my public and private job, unfortunately, is that when obviously I have a black client, they say, oh, send Xavier straight away. But I always tell them, no, I always tell them to ask the patient, if the client, if that's what they want. Sometimes it is what they want, sometimes it isn't. And I think that it's good to respect that. Other times I've also found in other settings is that opening up to your own people, especially if the experience outside of a clinical setting has been negative, it doubles down the room. They don't know me. They open up to your parents about depression. They say you're lazy. You tell your best friend this is going on. They say, oh, just get on with it. Then they come and try to open to another person who looks like their father, uncle, or friend. They think that they might get the same response, despite it being a mental clinic, despite saying it's safe space and saying all these things. So I think we just have to do more work to actually talk about how we actually do really take the job seriously and do try and make a safe space for them. Because a lot of people don't believe us yet, and that just means we've got more work to do. That's how I understood that question in that sense.
Thanks so much, Xavier. Thank you for answering the question. And I think, yeah, that's really helpful to Teresa and adds like a different element to the conversation as well. I see your hand is up, Norma. I just want to go to the chat quickly and then we'll end with Norma's question. But this is from Tendai. Just putting my research hat on. Wondering, is there anything we can do or suggestions in the Australian context to build evidence and push policy on what African mental health care should look like so organizations are informed based on evidence? Maybe I can pop that to you again, Xavier, and then Tracy, if you had anything to add, that would be great.
Yeah, no, it's coming up. There are many researchers, black academics who I think some in Adelaide reached out, some in Sydney. The tricky part is that people who want to do the research, can you get people to come and engage in the research? So the government, obviously, on a lot of these organizations need figures. That's how businesses work, that's how institutions work. Give us some numbers. What are we working with? And the tricky part is actually when you set up these surveys and when we try and do research and say, open to this demographic, no one comes. You almost have to start forcing it on people, but you find that the community is still not sure what you're doing. And maybe it comes back to what I mentioned, that your building is the barrier. You're talking from a research institution that people haven't trusted historically for minority issues, and you're coming to say, no, no, we're the good guys. And I think that's the big barrier we're having, that the uptake of people engaging in research, surveys, being able to follow it up, even though it's anonymous. A lot of people still don't trust that, and that's one of the big barriers. That's why a lot of the research I put in, like, it's not high level research sometimes. That's why surveys or anonymous surveys tend to be how we start off. And when you try and do a full research project, it's hard to just recruit the numbers and people. And if you don't have that and you go to a government or organization, they're like, listen, I know you have something there, but we need something more tangible than just you feel it and you're from the community. Sometimes they can go off that, but more often they need a bit more than that. So I don't know if I've answered your question, but the evidence, we extrapolate a lot from the UK, American, even Africa. There's a lot more people doing it. So the evidence sort of says the same things: lack of education, the stigma, culture, lack of psychosocial education. Like, do they know what mental health means? What does depression mean? We're so many levels behind that if you get on those, um, hit those marks, eventually you get there, but we're not really there yet as research. But people are trying, though. I should let people know. Every year there's a research trial from someone doing a PhD who's putting in the community, and it's we're trying, I guess. We're just not there yet, I feel, with the community.
Just to quickly add on to Xavier, I think it's there's definitely some challenges that are still left there. And Tendai, you raised a great point, and it's actually a topic to be unpacked even further. But certainly nowadays, there are a lot more groups that are working in silos. And what will be helpful is when we actually unite to be able to actually have more targeted priorities in terms of like the research that we're doing within the African communities. But certainly peak bodies like AAAC, so African Australian Advocacy Centre, will be one avenue to ensure that we have that connection to government and also be able to undertake research that's meeting the wider community, but also the African community's needs. So there's a lot more to be unpacked there. Definitely 30 seconds is not enough to share that.
Thank you, Xavier. Thank you, Tracy. I see more questions coming through, but I did say we'll go to Noma, who had a question, and then we'll hopefully be able to get through. I see, yeah, there's definitely a need for more of these conversations to happen, Tracy. That's what I'm getting from the chat as well. But Noma, did you have a question you wanted to ask?
So my question is related to the South African side. So I know in my culture, we do connect with traditional healers and such. But in terms of when there is that sort of, I guess, I don't want to use confrontation, but that friction almost between a parent who maybe is completely against it. Like in my case, the school on my behalf sorted out a school counselor, but it took the principal actually talking to my parents to allow that to actually happen. And then and I went to an all white school, so it's kind of like an older white person telling my parents about what their young black daughter should be engaging in was kind of difficult. So, from the South Africans' perspective, like, how do we kind of navigate around that, maybe that friction between parents who think, no, this is a white thing, this mental health thing is not part of us or our culture? Yeah.
Thank you, Noma. Edward, are you happy to answer?
Oh, yes. Thank you, Nama, for that question. Well, what we have seen, like what I've just suggested in issues of collaboration, it is mostly about education because people need to understand what is happening, what could be the condition. For an example, if the person has been diagnosed, how does it affect an individual? How does it affect their lives? And how can it impact their families and their surroundings? So when people have the right information, the right knowledge, as well as even the people that the parents are consulting, they're able to guide them as well. That I've seen in cases where that a traditional healer can see that, I cannot be able to deal with this problem, or I cannot be able to handle this problem. Let them be transparent to that extent that they are able to also refer to other service providers who can help the person instead of just trying to do everything by themselves. So that's where we need that form of a collaboration, that when I bring my information, when you bring your information, and then how we can meet, in between.
Thanks, Edward. Thank you so much. I'm just wondering, is there time for one more question, Tracy, or? I see that there's just a question in the chat saying that there are a lot of spaces being created to support the wellness for African women, and the men are lagging behind. What can be done to bridge this gap? I'm not sure if you want to speak to that, Tracy or Xavier, and then we can wrap up. Sorry, everyone. I know lots of questions, and again, I think it just shows the need for this conversation to continue.
Yeah, no, I'll definitely take that one. And I think we'll also have to discuss this offline because it's such a loaded question in itself. And you're right that I think when we talk about gender, there's a lot more, I guess, mobility within women's spaces when it comes to addressing mental health. Unfortunately, for the male counterparts, I know in the wider community, there are a lot more groups that are catering to men, but they're not nuanced or specific to Black and African Australians. So that will be definitely something to even discuss further. And I know Xavier has had a lot of work in that as well. So I think it'll be great to take it offline with Xavier too, because I know he's definitely leading the work in there as well. But thank you so much for that question. So I just want to provide the final reflections for tonight. So thank you again to everyone for attending and for those insightful discussions and every contribution that was made. It is really a start to what could lead to deeper conversations, and it definitely seems like there's a lot of appetite around this. So I hope I do justice in terms of summarizing what we heard today. But we heard from Noma, who was talking about the deeply personal reality of navigating mental health services, but from a point of view where she also found hope in culturally grounded support and community care. She reminded us that identity and belonging are quite central to recovery and called for systems that truly listen to lived experience. Then Xavier really provided a clinical lens that was highlighting both the progress and the persistent gaps in culture safety across Australian mental health care settings and the wider settings as well. His example around embedding culturally responsive practice in routine care showed that meaningful changes also begin with just small and consistent actions that are supported by leadership and accountability. Then Kurt shared from a lived experience perspective about how there are challenges navigating systems, but the support networks in his case really were helpful in those situations. His call to policy makers was also quite clear, which is co-designing systems that reflect community realities is very much needed. And lastly, Edward really brought a systems and service delivery view, demonstrating how partnerships, outreach, and even the respectful inclusion of traditional healers can make care more accessible and relevant. His recommendation reinforced that collaboration and cultural respect must underpin every mental health strategy. So together, these voices really reminded us today that cultural safety is not just a tick box exercise. It is a shared responsibility and a continuous practice of listening, learning, and doing better. So before we close, I just want to gently remind everyone that today we did have conversations, or we heard some stories that could have brought up some strong emotions or memories. So if you do need support, please reach out. As mentioned, Stephanie and Secunda are still on the line for one more hour, so you can definitely contact them. We also did pop the crisis lines, which are being displayed right now, but that's something that you can also access if you do need to talk to someone. Now, I want to leave everyone with a collective call to action, which is quite simple, but I hope that it's powerful, which is please continue these conversations. Take what you've heard today, what you've learned, back to your workplaces, your communities and policies, and help make mental health care safer and more inclusive for everyone. So thank you so much for being part of this important dialogue, and have a wonderful night or the rest of your day. But thank you so much for attending.
Everyone. Bye. Thank you.
Bye.
Thanks, everyone. Thanks, Tracy.